All right, are we all ready? Looks like it's 8 o'clock. Good morning, everyone, and welcome to our panel on overcoming obstacles, identifying barriers and opportunities in telehealth. If you have any questions during the conversation, please type them into the Q&A box at the bottom of your screen as they come to mind. We will save some time at the end for those questions for our panelists. Thank you to Robin Moki, Rebecca Skoog, and Leah Malloy for helping to pull this panel together and all of their behind the scenes work. So we have a great group of panelists with us this morning, and I'm really excited to hear all of their perspectives on telehealth from each of their disciplines. I will be introducing them shortly, but I wanted to first give some brief introductions, starting with myself. I'm Sarah Compton, and I use she, her pronouns. I've spent 10 years in healthcare and public health in Montana. I built and coordinated a telehealth program for a health system in Montana and did that for 5 years. Currently, I am a contractor with Upstream Health Innovations, LLC, a healthcare consulting business, and I also serve as the vice president of the Montana Telehealth Alliance. So even though telehealth has been around for decades, perhaps one of the few silver linings of the COVID-19 pandemic has been to force telehealth into the limelight. COVID has done more for telehealth in the past 12 months than any of the past 20 years, almost. We are all, excuse me, waiting and watching to see what, if, and how many changes that have put in place during the public health emergency become permanent. I wanted to touch on some of the biggest changes that have occurred and are currently allowable during the public health emergency. So these waivers that have been put in place have really opened up billing and billable services for all providers. So prior to COVID-19, Medicare, the Centers for Medicare and Medicaid only recognized a very limited list of eligible provider types that were able to provide telehealth services. And now all of those restrictions have been removed. Any provider type can provide telehealth services. CMS also expanded the originating site options. So again, prior to COVID, telehealth was only allowable in certain facilities to be billable for Medicare, and most private payers follow what Medicare allows. The waivers also removed rurality restrictions for telehealth visits. Prior to COVID, there were only, you couldn't do telehealth with some exceptions in urban areas. It wasn't a billable service. They've also removed HIPAA requirements for telehealth software. Again, when everybody was standing up telehealth in March of last year, that had to happen very quickly, and CMS has allowed for some traditionally HIPAA secure or compliant platforms to be leveraged for that use as well. And one of the last big ones that I'll mention today is that CMS also currently during the public health emergency allows for, audio-only visits to be billable in addition to the live video visits, essentially what we're doing today. So those are some big changes that happened and has allowed additional disciplines to leverage telehealth in order to serve their patients and their patient populations. I also wanted to make a quick note on telehealth language and terminology. Even though telehealth has been around for a long time, definitions still vary across organizations and entities. So for the purposes of today's presentation, I want to just quickly describe and define the following. I think one of the biggest ones that trips some people up is the difference between telemedicine and telehealth. Telemedicine traditionally is the providing services from a medical or clinical standpoint. So if you're thinking about a doctor and a patient, that is definitely considered telemedicine. Telehealth is used to as a much bigger bucket to catch all of the different technologies that are being used Also to include other disciplines that aren't necessarily traditionally clinical, and to also include education and some other modalities as well. So hopefully that helps make that distinction. They are oftentimes used very interchangeably, and it is okay if you do. It's just, I think, helpful to have that little distinction there. Another distinction I'd like to make is between what the Center for Medicare and Medicaid determines is an originating site or a distant site. So the originating site is where the patient is located. So if you are a patient who is at their home is the originating site. That is where that service is being provided. And the distant site is wherever the provider is located. And then I just wanted to touch briefly on, because this came up in one of our previous conversations that we had with our panelists, telepresenter is someone who is not the person receiving the services, but may help out with facilitation of that visit. This is also referred to as an e-helper or a telefacilitator. So those are some very useful folks to have around, especially if there is a visit or a type of visit that requires some additional assistance. So those are the terminology that I would like to cover today. So I would like to introduce our panelists now. We've got a great group today. Janneke Volkert has been working at the University of Montana's Curry Health Center for 5 years. She is a family medicine physician and has experience providing primary care for patients of all ages, but especially loves working with young adults. Janneke trained at Dartmouth Medical School and completed her residency in family medicine in Portland, Maine. When she's not at work, she loves spending time on the trails around Missoula with her husband and 2 young boys. Welcome, Janneke. Hannes Heppner is currently a 3rd-year clinical psychology doctoral student at the University of Montana. He's also a graduate student clinician at the Clinical Psychology Center, where he provides therapy under the supervision of licensed psychologists. Prior to coming to the University of Montana, Hannes received his MS degree in clinical psychology from Steinbus University in Berlin, Germany. Hannes subsequently worked at a geriatric hospital near Berlin as a psychotherapist, and he received his BS degree in psychology from the University of Washington in Seattle. Welcome, Hannes. Jenna Griffin is a speech language pathologist and clinical assistant professor in the School of Speech, Language, and Hearing and Occupational Sciences. She also serves as director of the Big Sky Aphasia program at the University of Montana. She supervises and mentors graduate students studying to become speech language pathologists. Her areas of interest include psychosocial well-being and social isolation for older adults with neurogenic communication disorders and holistic rehabilitation that includes the care partner of the individual with aphasia or traumatic brain injury. So welcome to you all. Just want a quick note, Steve Ferdig was planning on joining us today, but unfortunately wasn't able to make it. So we just wanted to recognize that he was definitely, would definitely be missed for this conversation today. Okay, so I'm going to hopefully stop talking for a little bit. I have some questions for our panelists today. First, want to start with some really general sort of getting to know your clinical areas and how they were impacted by telehealth. So, and we're just going to do sort of a round robin. We're going to have a conversation today. I don't really have any strict format. So for our panelists, you can answer questions as they come up, and I may direct some questions to you as we go along. So can each of you briefly explain your pre-pandemic clinical experience and how your clinic and your colleagues made the switch from in-person to telehealth visits?
I can go first.
Great.
So I work at Curry Health Center, so at the University of Montana, serving university students, and we are a primary care clinic, really providing pretty general care on kind of all medical issues, as well as some urgent care, sort of acute care. Um, and prior to the COVID pandemic, we really didn't do any telemedicine, I would say. Occasionally I would have phone visits that I wasn't charging for that were kind of follow ups when somebody would start a medication. But technically, I was not really considering those telemedicine visits. And when the COVID pandemic came on, we never fully closed. So we continued to provide care throughout. And at the beginning of it all, we really wanted to limit people coming into our clinic for the safety of everybody. And so, pretty quickly, we moved to offering telemedicine, and we were lucky to have access to a HIPAA secure Zoom early on. And so, I would say within the first few weeks, I think we started offering telemedicine. But there was definitely kind of lower demand, and people didn't really know what telemedicine was. And so there was definitely a learning curve. And we still continue to see some patients in person if needed. And so we've offered that throughout this whole pandemic as well. Um, I'll stop there and let other people speak, but can go on into more detail later.
Yes, and I'm sure we will. Thank you.
Yeah, I can share. So I work in the DeWitt Right Care Speech Language Hearing Clinic at the university, also actually in the Curry Health Center with Yannicka, but in the basement of the Curry Health Center, the garden level. And so, interestingly, I personally have had some experience with telehealth over the previous 4 to 5 years, but it was just a very small subset of our patient population. And so, maybe 1 or 2 clients every semester that we would see via telehealth. And so it was a pretty massive transition, kind of like Yannicka said, and a pretty quick transition last March when we moved from mostly in-person services to exclusively telehealth services. And part of my role, kind of like Sarah said in the introduction, is that I supervise graduate students. And so this was a massive transition for our graduate students who had to be incredibly quick thinking, incredibly fast to transition to this new model. And they were no longer able to come into our clinic. So they were doing all of this from their homes, where maybe even our students didn't have great internet connection. And then they were transitioning to doing telehealth and gathering what materials they could. And if you all remember, that was right before the university spring break. And so some of them had gone off to their spring breaks to their homes without all of the materials that they used for their day-to-day therapy sessions. And so yeah, obviously I think for all of us, just a massive transition. I did feel really lucky in that I had already had some previous experience with telehealth, and some of our students were able to train each other, which was incredibly beneficial. And like Yannicka said, we also had access to HIPAA compliant Zoom, and that was something we had in place previously to the pandemic, which made the transition exponentially easier, I think, for all of us. And yeah, I'll later talk maybe about some of our patients and the transition with that, but it was definitely a significant change for all of us.
Yeah, so yeah, I work at the Clinical Psychology Center as a student clinician, and I had no experience in telehealth before the pandemic hit. And I know at the Clinical Psychology Center, there was next to no telehealth either. There were some, I know there was like a few instances, but that I'm not very familiar with, but it was few and far between. And then once the pandemic hit, the Clinical Psychology Center had to, like most other disciplines, had to scramble a little bit to adjust. And so the clinic, I think, closed so it didn't provide services for a week to adjust all of this. But after that week, kind of went back into service, and we also used a HIPAA compliant Zoom. And it was just difficult. I think mostly from many different perspectives, but the logistical component of it was quite challenging from before the pandemic hit. Everything was in-house, like in this clinical psychology center, everything was located, all the notes, all the videos, everything therapy related went on in there. But then after the pandemic, that all had to transition out of at like 100% out of the clinic. And so it went into students' homes and therapists' homes, and to make that happen technologically. And then also, yeah, I can also talk later about how that was from a treatment perspective. But that was for sure the biggest transition to make. Mm-hmm.
Yeah, well, I'm so glad that you all are using and were able to leverage HIPAA compliant software from the get-go. I know that the waiver was put in place to just allow for that expansion so quickly, which is one of those just because you can doesn't mean you should situations from like a clinical care perspective. So kudos to all of you for being able to leverage the best technology that you were able to. So as far as like moving from all in person, mostly in person to telehealth, it sounds like it was a bit of a scramble. I think that that's a pretty common sentiment. Did you have any access to any resources or training guides from your areas of study or your professional associations to help with that transition, or were did you leverage any tools or tips, or was it sort of a blind leading the blind situation? And I guess as a sort of a follow-up, like, have you established any best practices? Like, how did it evolve from the very beginning to sort of how you're doing things now?
I personally did watch a webinar that was on telemedicine and telehealth. I don't think our whole practice necessarily watched that particular one. I think it was a little bit just trial and error, and not having, honestly, like a lot of guidance. But we did, in terms of kind of the legalities of it, we asked for advice with legal related to and making sure that we were complying with practices legally. But yeah, I think most of it for us was really like learning on the go and not having a ton of outside guidance. And so I think as we move forward, we're just trying to keep an eye on kind of the federal guidelines and rules and how this all evolves so that we stay compliant. But yeah.
I think a similar experience, I think initially, because everything was in such flux, like we've all said, like we were all just trying to shuffle around and make things work. I wouldn't say there was a ton of initial guidance like from our national governing body, but actually our state organization, the Montana Speech Language Hearing Association, was really fast in putting out some of these webinars, trainings, also, just general information about implementing telehealth, which was great. Something that I have found really challenging over the course of the last year and plus is that things have changed so dramatically. And so, I think one of our biggest challenges, and I really credit our clinic director, Leah Malloy, who's on this call, like with keeping us up to date with these changing things, right? So changes in, especially as a graduate training facility, changes in how much our students needed to be supervised in any given session, that has changed numerous times. And how many students could be involved in one session has changed a couple of times. And so I think people put things out as quickly as possible. And I was really impressed, like I said, with our state organization. But because things have changed so frequently, it's really, the onus is on all of us, I think, as clinicians, to stay super up to date with the changes that seem to keep going. So that's, I think, been kind of a challenge as this process has continued.
Yeah, I mean, I would agree all this with all of this, and I know from the American Psychological Associations that's quite a bit of guidance that came out fairly quickly that helped to adjust to it. And there's a lot of small things that they help with. How to set up a Zoom background, and how to position yourself. What's the lighting like? So simple things like that. They were They were really helpful in providing guidance. And I know from our clinic director, Dr. Rory Birch, she has communication with a bunch of other clinic directors throughout the country, and they were communicating with each other on how to set that up because they were all in the same boat on that. And we also have a psychologist who's affiliated with the program, who worked for the VA, who provided teletherapy for quite a number of years. And we had a little webinar with him where he kind of introduced what it would be like and what to pay attention to. And so that was really helpful in setting it up. But that came all, I mean, it all came in one swoop, so to say. I mean, the pandemic hit, and then we already provided the therapy, and we had all this training all simultaneously. So, and this was all early on kind of packaged together. And so that was a lot to kind of process cognitively. But then it helped to just pay attention to all the things that needed attention. I mean, apart from the logistics and the legalities, but then also how to conduct the treatment in the best way possible. Yeah.
Yeah, I think this is a good segue into sort of the billing and regulatory side of things. Knowing that you all had to make the switch so quickly, was there a time where, I guess if you could talk to me about the journey from like just needing to provide patient care to then making sure that you're actually getting reimbursed for those services in a way that, makes, I know that a lot of you are in different clinical settings that are, within the university, but from a financial sustainability standpoint, how have you navigated that in terms of the finances and the switch to telehealth?
I can chat a little bit about that. I just want to acknowledge too that I try, we have the luxury to have people who take care of our billing and who navigate a lot of that. So this is from my limited perspective as a provider and as a supervisor. But I think that, again, it's kind of been this ongoing thing. And I think initially last spring in particular, the solution we came to was, I think you alluded to this, Sarah, right? We have to keep providing services, but there's no sort of billing regulations or anything really set in place for us. And so that was definitely a challenge. And I think all of those sessions probably just ended up getting written off and not billed. But again, I think it's like the same thing I was kind of saying on the last question. It's like, it's been this ongoing and changing process. And so many of the patients I work with, as you mentioned in the intro, have neurogenic communication disorders. So tend to be older adults, tend to have Medicare. And so of course that has been an ongoing and constantly changing process. And something that has been really nice is that Medicare previously for speech language pathology services didn't cover really any of our patients' services. And of course, now they've put some regulations in place that they do cover some of these services, many of these services. And so that's actually been a really positive thing from a sustainability perspective. And I truly hope that that's something that continues to exist down the road.
Yeah, no, at the Clinical Psychology Center, we don't work with insurance companies, so we don't have that problem, luckily. But it was still, I think there were still a few challenges because when pre-pandemic times, we would just like after the therapy session is over, the clients would pay right away. And so there would always be, the clinician would be there too. And then after the pandemic, there was quite a few ways that was initially done. And, for example, clients were given the option to mail in checks or to call in to pay. But I think there was, for one, this is, there's a security issue here. I think that clients had a little bit of discomfort. And then also, it's just, then it's another, it's just, it can be a barrier to do that, to regularly call in and to make these payments. Especially then in pandemic times, if quite a few people lost their jobs and finances weren't as secure as they were pre-pandemic times. So and keeping cards on file is also, a little bit iffy for clients, and totally understandably why. And so there, from that standpoint, there was a few challenges, but thankfully we didn't have to do any sort of billing with insurances.
And Yannicka, are you in a similar situation about, yeah.
Yeah, so similarly, we don't bill insurance, so we're lucky that we can kind of choose what we charge for our telemedicine visit, and we really try to keep prices really affordable at Curry. And but I mean, I've been trying to follow sort of what's happening in the medical world outside of our university, and it does seem like telemedicine is being reimbursed by insurance companies in a more broadly, and I think that trend is going to continue, and I think that is a silver lining of the pandemic, that luckily it's a really, I think, useful thing to be offering, and so I'm glad that we'll be able to hopefully continue and be paid for it as well.
Yeah. I'm going to ask about technology now. You all mentioned that you went up on HIPAA compliant Zoom. What did you have any challenges with the technology getting that set up? And are there anything that you can share about the challenges and successes with the technology side of things?
Definitely have a few thoughts on this. I think, first things first, we are in Montana, we're in a rural state, and we're serving clients and patients who may not have access to great internet. And so I think from my perspective, that's been one of the biggest challenges for both our patients and the student service providers who are in their homes. Is just navigating the technology to be able to provide or receive services. And I do think it's gotten a little bit better, thankfully, but that was one of our initial, issues, particularly early last spring, was just as we're serving these rural individuals who, some of them still have dial-up, or some of them are still, going to their library or their sister-in-law's house or whoever to log on to their sessions. And so that was a big challenge. Unfortunately, there's been a couple of patients in our graduate student clinic that we've had to discontinue seeing because of just, the rurality and just lack of adequate access to internet. However, I think, kind of thinking of the silver linings, I also think so many people, I've just been so pleasantly surprised by how many people have figured it out. Like, they make it work. They go to their sister-in-law's house, and because their internet is not great at home, and they've just found really innovative ways of navigating the technology. I personally was really nervous because, again, I work with kind of this older population of adults, and I was a little bit anxious about how will they access Zoom, even though it feels, I think, like second nature to all of us now, especially at the beginning. Like, will they be able to navigate Zoom? Will they be able to log onto a session? And of course, I'm working with individuals who have communication disorders. And so giving them instructions on how to log into a Zoom session if they have a reading comprehension deficit isn't going to be effective. And, some of them had e-helpers, or telepresenters, I guess is the other term you can use. Some of them had that, which was fantastic. But what I've been really surprised with, very pleasantly surprised with, is how many of our patients have been able to navigate technology, figure out how to log in, and most of them have gotten better than their care partners at navigating. Even the people who have communication disorders, they've gotten really good at it. And I think, I don't work with pediatrics, but I think, parents have been really effective on the pediatric side of our clinic in being able to help get their children online, serve as an e-helper so that they can kind of stay focused. So I think there's been good and bad, but I think overall majority very, very positive with technology.
Yeah, I mean, I think that's also true at the Clinical Psychology Center. There's a lot of things that Zoom helps with. Like clients, for example, sometimes are on their phones, they can choose the place they want to conduct therapy from, which has benefits and drawbacks. That there is something to be said about going somewhere and conducting therapy in a pretty stable setting, or at a destination, so to say. And so that has been a little, the jury's still out on this, on what exactly the effect of that is. But Zoom, but the Zoom technology or the health in general has enabled people to conduct it from wherever they feel comfortable, which is helpful, for example, for people who have anxiety, or who just have financial barriers or any other barriers, and so that has really helpful to enable people to seek help and therapy. That being said, sometimes the internet connection is wobbly, and that is especially problematic when when there's an ongoing sessions. And I've had that a few times when I'm talking, then all of a sudden it cuts out, or the video is disrupted, or the battery's dying of the cell phones or so, and so that has been a little bit challenging. Yeah, so I think overall, I mean, there's definitely benefits of it, and but also challenges, but what the effect of those challenges are on that the next few months and years, I think will show too.
I'm going to go ahead and pipe in here too, because we have an interesting comment in the chat from someone who has the billing for PT and speech clinics. Dara or Dara, I apologize if I'm saying your name incorrectly, but she said that she does billing for the PT and speech clinics. And early on, there were many discussions almost daily about the changes. We in the PT clinic attended many webinars on the changes and found that frequently the information discussed in these was actually incorrect. We quickly adapted a policy of let's just try it and see what happens. And in many of these cases, we were paid and we were paid and then reimbursed. And then we knew we could continue to use this method to be reimbursed. So it sounds like they even had to kind of go off on their own and branch out a little bit. So thank you for sharing that. It's nice to have that PT perspective.
Yeah, definitely. Thank you for sharing. Yannicka, did you have any thoughts on the technology side of things?
I think I work with the university students who are pretty savvy with technology for the most part, and we're able to navigate the Zoom sessions pretty well. But I agree, internet service was sometimes a problem, and often we'd have to turn video off and then go to audio only. And I definitely think there's a difference in the quality of care when you have audio only. For certain things it's fine, but sometimes it's really not as ideal. But yeah, I think in general, that our population has been really happy doing telemedicine and having that option, and the technology hasn't been a barrier for us, luckily.
Yeah, that's great. I do want to just quickly, having been in the telehealth world for a while and I've been attended many conferences and webinars on the subject. I think there is definitely a sort of a generational, hopefully, I think a generational shift prior to a generational assumption that older folks didn't know how to use the technology, which I think is just not necessarily. I think in some cases it is, but I think you also have a fair amount of younger people who also, have a hard time navigating the software. There are plenty of grandparents who have been FaceTiming with their grandchildren for years. And so I think that as the technology continues to continue to be affordable and available, it's just, part of the way that we communicate with our, friends and family, and now our medical providers as well. So yeah, it's interesting, the sort of cultural change and all of that. So thank you for that part of the conversation. I want to move on to some questions on student supervision. I know, Jenna, you mentioned that you supervise students. It's a student-run clinic, and that there were some challenges with that. Can you talk more about how that impacted the students and then also the supervising? Talk to me more about that.
Yeah, I think there's so many things, right? So, and of course I see that a couple of students are in the audience, so you guys can feel free to add in your perspective, because you've been doing telehealth now for almost a year, into the Q&A if you'd like. But I think, yeah, so it's been this, it seems like we've been through such a long period of time, but I think it's kind of gone in stages, right? So at first it was this, again, as I mentioned earlier, we had a few students who were doing telehealth. So it was a lot of like peer training models, which was fantastic. last spring we actually had was the first time we had, or I personally had paired up students. So one of our governing bodies kind of gave speech language pathologists permission to have like 2 students on a single session with a patient and both get clinical clock hours. And that was actually a wonderful, so this paired model is what we call it. That was actually an amazing model because we had a couple of second year students last year, second year graduate students who were about to graduate, who, because of the pandemic starting, had their last placements canceled and weren't going to acquire and accrue enough clock hours to be able to graduate. And so we had to be really fast thinking to get them their enough clinical clock hours. And so we were able to do some simulated experiences, but then also to do this pairing model for some second years. And it was just like a wonderful experience because we had students who had a little bit more experience who were now kind of peer mentoring students who were newer to the clinic. And that was a really lovely model and has been something that I think we'd all really like to continue with. And then in this last year, in fall of 2020, and then in the spring, as we continue telehealth services, these students are continuing to be paired. And now I never want to go back because the feedback has been so powerful from the students in the ways that they learn from each other. And so, for example, 2 of my students would each have like a primary patient that they would work with. And then for the other patient, they would be the secondary clinician. And so they'd get to watch like other ways that their peer is cueing their patient or is taking data or is having, you know, social interactions. And that's been such a powerful model. And I think even when we return to more focused in-person services, I'd really like to keep that model because the feedback has been so wonderful from our students. I think I went a little off topic with answering your question though, Sarah. I'm so sorry.
That's okay. No, it's all good.
Like in terms of supervision, I can talk about my own experience being supervised. And I know that in the beginning that was, it was challenging and also super unfamiliar to do this all over Zoom. For at the CPC, what typically happens, there's recordings of the therapy sessions, and then student clinicians would watch those recordings with their supervisor all over Zoom. And so that was for sure, that felt foreign in the beginning. But it was also helpful because you can do it from anywhere, and you can basically, and once we got habituated to it, it actually was very helpful too. I mean, it wasn't a big disruption, I would say, in the supervisor-supervisee relationship. I think that the challenge, and I don't do this either, I don't work with children, but I think where the challenge was in terms of supervision and treatment was for school psychologists in training who had to do assessment and give measures. And then some of those measures you can do over Zoom. The CPC and Dr. Birch were pretty incredible in making this all happen with Gris Tech, or with whoever the tech experts are at the university, to kind of have some of these measures all go online and send links around for them to fill out, but some measures you can't do. I mean, especially the school psychologists, when they do their assessment batteries, they would invite the parents and the kids into the clinic, and they would do it somehow. There are some sub measures, but then do all that's possible over Zoom. And so I think that took some figuring out too.
Great, thank you. I'm going to move on to I know that we have a lot to talk about in terms of workflow, so I want to make sure that we have enough time for that. In terms of workflow, just because you can do telehealth doesn't mean you should. Janneke, you mentioned this earlier about audio only not being you thinking that that's a good quality of care service, that it's fine for some but not for others. So have you encountered any other instances where you're like, well, maybe this shouldn't be a telehealth visit, or surprised that you could do a type of visit via telehealth that you were sort of hesitant to at first? And then also, what types of visits do you think are best suited for telehealth versus in-person visits?
Well, I can speak to working in primary care. I've been really pleasantly surprised by how much you can do in a telemedicine visit, and it's a little bit sad that the art of the physical exam is getting lost a little bit. But honestly, we as medical providers don't really rely on the physical exam as much as we used to. And so that is the part of telemedicine, or the part of the telemedicine encounter, that I feel like you can't do as well. But I am just in my sort of learning about telemedicine and reading and attending other um, educational panels, kind of learning that there's actually a lot that you can do in terms of a patient guided exam. So personally, what I tend to see the most at Curry Health Center is a lot of like mental health care and psychiatric care. And so that has actually been really great in telemedicine for the most part. I think a lot of patients are more comfortable kind of talking about these really private, personal things in their own home. But there are certain challenges to kind of developing a rapport and relationship with a patient when your only kind of interaction with them is via video, or especially phone. Like for myself, if I have a audio only encounter and I've never met someone in person, to hear about kind of their challenges and struggles and not have a face to put them to, and kind of really know, it's really hard to really kind of understand what's going on without seeing them. So personally, now that COVID has improved, the pandemic is improving, I am trying to encourage people to come in person for any like new patient visit where I am meeting them for the very first time. And then for follow-ups, I find it totally fine to do those by video. But yeah, I think establishing a brand new relationship with a patient is tough electronically.
Yeah, so when we do therapy over Zoom, I think there's a big benefit in being able to conduct it from anywhere. But the drawback is also you can only see the face. You only see like such a small part, and some of the body language gets lost. So I would definitely agree with Yannicka. The benefit of it though is also that you can get a glimpse into where people live. And you can see the surrounding where they are at, and you can see changes, when they change locations or when things change in the environment. And so there's, with that, the video function of Zoom is nice in that regard. But yeah, for sure, with a rapport building, that's difficult. Although, over a few months of doing this now, I think we kind of habituated to it. There's a way of engaging with each other over Zoom, where we're kind of, there's almost this common ground that you get to, and then I don't know, it feels more natural now that we've all done this over so many months. It felt much more foreign in the beginning, I feel like.
Yeah, I definitely agree with what the others have said. Although we don't have the option for the audio only visits because, for shaping certain sounds in terms of thinking about communication, that's just not going to work. But I definitely have had similar perspectives. I think Hannes just pointed something out that really made me think I hadn't even realized until just now. So this is like a really good learning experience, I think, for all of us, about seeing their environment and how important that is. And one of the things that, we are always talking about from the lens of speech language pathology is trying to make it more functional, and more generalizable. So I always tell my patients, like, okay, it's great if you're doing great in the therapy room, but like what's more important is that you're doing this at home. And so we've been able to incorporate, maybe we show them a picture of a cat and we're working on the word cat or something like that. And then I'm like, whoa, oh, I just saw your cat in the background. Why don't we like talk about your cat? And it's a really nice way to generalize these communication skills that these patients are retraining, or in the pediatric sense, learning. So that's been one huge benefit that, again, I hadn't even really thought of until now. I was like, of course, that's a significant benefit of telehealth. Another benefit is being able to involve the care partners more. And so not just as e-helpers, but in functional communication settings. And that's been incredibly beneficial for our patients as they work on growing their communication skills, right? It's one thing to communicate with your therapist through in the room or via computer. It's totally different when it's your daughter or your grandson, right? Or your spouse. And so that has been just like another unexpected benefit, I think, of the kind of home environment. And then something that's been fantastic for our students is that I think that they've gotten a lot more creative in material creation. So in speech language pathology, there's a lot of materials that you have to create for various treatment tasks. And I was pretty nervous about that because like historically they've like printed out pictures and then they've looked at them in the room together, or they've used a whiteboard in person. And we've been able to use the functions that are offered through Zoom, like the whiteboard, and then share screen, which has been incredibly helpful. Something I was nervous about and that has been a little bit harder over the telehealth modality is some of the tactile cues that we can't give. So being able to, especially for like cueing really fine motor movements of the mouth, that has been a little bit more challenging. And also sometimes to be able to see those fine motor movements in a client who might have like a unilateral facial droop or something like that. It's a little bit easier to see that and cue for that in person. And that I think is the one challenge that remains. But again, I've been pleasantly surprised with the overwhelmingly kind of positive things. One thing that people definitely need is adequate attention skills. So because we're working with individuals who have communication disorders and sometimes cognitive communication disorders, if they don't have good attention to be able to maintain for an hour or even sometimes a 90-minute session, telehealth is really not a feasible option for them. And I would imagine on the pediatric side of things, it's probably the same thing. Although again, I don't work with that population, but having your kiddo sit in front of the computer for, although they've all done that now with school. So they're probably getting pretty good at it. But I think attention skills are really important to be able to successfully have an interaction.
I'm on mute. Thanks, Jenna. You talked a little bit, Jenna, about some workflow modifications that you've made due to telehealth. Want to open it up to Hannes and Janneke as well. Any workflow modifications that you've made that has been really helpful when navigating telehealth?
I think the biggest one is that the CPC now has a separate consent form for telehealth. I mean, to set that up. And then also we spend a time at the beginning of treatment when a therapist and a client just start working together. We start. I think the workflow adjustment is to kind of talk through what the Zoom session is going to be like, or the treatment over Zoom, and then also how to set that up. Like to seek a space where there's privacy ensured. And on the client side, but then also on the student side, that you have a background where it's not distracting, and you're positioned right. So there's been, that I think is a workflow adjustment that we do, especially in the beginning. We also make sure that we know where the clients are at all times to just ensure security. If there's suicidality or anything like that, we have a way of knowing where the patient is, and then also have another contact to get to the client if something happens. That's obviously not necessary if the client is right in front of you, but that's been, I think, from a policy standpoint, that's probably the biggest adjustment in the CPC.
I think similarly, things like consent forms, and we have other forms that we have patients fill out. Sometimes there's like symptom surveys before a visit and that kind of thing, where we would have given them a paper or done it kind of in the room with them. Now we're trying to have everything where they can access it before their Zoom session electronically and then submit it so that we have those in advance. And so we just changed our electronic medical record a little bit. And so we're still trying to figure out how to optimize kind of the interaction between telemedicine and like our EMR and sort of streamline that. But yeah, workflow wise, like for providers, figuring out a space, like we have shared offices, so we kind of had to change logistically. So each of us had a private space where we could do Zoom sessions to not have interruptions. And then on the patient side, like Hannes was saying, like making sure the patient knew that it was important to be in a private space and where we kind of had an understanding of where they were if there were a safety concern and we needed to get help for them. Yeah, that's what comes to mind off the bat.
Great. And Jenna, did you have anything to add? Just I don't want to know. Okay. Great. I just want to check in. Rebecca, do we have any questions from the Q&A? I know that we're about 10 minutes. We've got 10 minutes left. I want to make sure that we leave time for anybody.
Yeah, we do have at least one question in the Q&A from Mandy.
Okay.
It's under answered right now, but it is not technically answered.
All right. So Mandy asks, assuming telehealth will continue to be supported by health organizations, is there an evaluation process for criteria that needs to be met by patients in order for patients wanting to attend telehealth services going forward? And is this something that must be pre-authorized by Medicare and Medicaid? I would assume for SLPs especially, and maybe psychology, there would have to be a criteria for services based on abilities and severity of disorders. I know the system is continuously changing still, so this may be hard to answer.
Yeah, so I think Leah responded to that a little bit, but yeah, so I think at least for speech language pathology, it's up to the provider to decide whether the patient is appropriate for services. So it kind of goes back a little bit to what I was saying in the last response, like with, having the attention skills. I think having potentially an e-helper there to facilitate, whether that's a family caregiver, whether that's another individual, maybe even sometimes like in a school setting, I would imagine a speech language pathology assistant potentially physically there with the child. But I think to my knowledge, it's primarily up to the provider to determine who is appropriate at this point.
Yeah, and I have a little bit of experience with this. Prior to COVID, we were doing, the health system that I worked for was doing a lot of direct-to-patient visits, but we had to call the insurance carrier to confirm that there was a covered service, and there was a lot of ambiguity around that. So it really depends on, this is obviously pre-COVID, and right now everything is okay. And talking about what's going to happen after that, nobody knows. But I think that it's the fact that we have had so much, like such a huge volume of telehealth visits, and I think that there are certainly entities out there studying quality and efficacy of those visits, and it will hopefully be some permanent changes. I don't know that we can expect all of the waivers to continue post public health emergency, but I'm hopeful and cautiously optimistic that some will become permanent, but it's really, nobody knows at this point.
I'll go back to the logistical question. One other big issue is with licensing. So our student population is transient and like moves from state to state, depending on whether it's semesters in session or some people have stayed home out of state this whole year. And so with the emergency authorization, there are some sort of it's a little bit looser right now in terms of restrictions for licensing and those. But in general, prior to COVID, I couldn't practice and serve somebody who was outside of Montana if my only license was in Montana. And so that is another part of this landscape that we're kind of looking at what those changes are going to be in the future.
Just
Yeah.
want oh, sorry, go ahead.
I was just gonna say that's definitely an issue here too in the CPC, is that once clients are out of state, then we can't do therapy sessions. They have to then come back to, or I mean, if they permanently leave, then another solution has to be found. But that's definitely been a big part of of just checking in where clients are physically. Yeah, for sure.
Same. Yeah, we've had the same experience where and it's also been, again, another thing that's kind of changed, right? So at one point we had a patient who relocated just for a brief trip, and we thought we were okay to provide services, and then found out later that we actually weren't, even while they were out of the state of Montana physically. And so stuff like that has been very challenging and unfortunately learned by trial and error. But same licensing issues.
Yeah, thanks for bringing that up. That's definitely a pretty hot topic in terms of, and it varies based on if you have a medical license, or based on your credentials as well. So yeah. I just want to give folks a reminder, if you have any additional questions, please pop those in the Q&A. Give a few more minutes for that. I do have another question for the panel. Regarding accessibility, how have you dealt with the accessibility issues for sight or hearing impaired patients?
I can briefly speak to that. I have a lot of patients, so the etiology of their disorder is a stroke, and so oftentimes they'll have like hemi neglect or a right visual field cut, for example. And so it has, again, been a lot of trial and error in terms of how large the font is on the material that we might be sharing via Zoom. Where we align, or we have their e-helper align the pictures of all of the participants, how, whether it's oriented to the left side of the screen or the right side of the screen. And something else, not exactly relevant to your question, Sarah, but really, really related for my population, is hemiparesis, so one-sided weakness or one-sided paralysis, hemiplegia. And, giving them, for example, an instruction to use the mouse is often not feasible because of weakness, or sometimes they also have limb apraxia, so they can't, it's really difficult for them to modulate the motor movements to then move the mouse. And so that's I don't have a list of great solutions for that, other than we've had to just make completely individualized changes based on who the patient is and like what types of difficulties they might be exhibiting. I don't have a lot of great thoughts on the hearing. I think it is definitely an issue. And I have not solved it yet. If anyone has any suggestions, I'm open.
Yeah, and we're not solving all of the problems today. We're just acknowledging that there are some limitations to telehealth. So in closing here, I just wanted to mention that not knowing what telehealth is going to be like in a post-public health emergency world, and sort of highlighting the silver lining side of things, telehealth turns out is like one of the few bipartisan issues that people can agree on these days. And on Monday this week, the governor signed House Bill 43 into law, which is a general revision of telehealth language in Montana Code Annotated. So we talked at the top of the presentation about the different terminology and how people are still trying to figure out, definitions, and those have been updated within the MCA. So it's forward progress. We still don't have payment parity. We do have coverage parity in Montana, which is definitely more than some states. And so we'll just continue the work that we do. And thank you all for the work that you are doing. as a closing thought, just as a brief last question, what is one hope that each of you have for the future of telehealth as it relates to your practice?
I can go first. I would say that I am hopeful that that it gets more integrated, so that there's a way to conduct treatments and therapy based on what the clients prefer. You know, some maybe prefer in person, some other prefer for logistical reasons, for whatever reason. You know, more hybrid model where there's maybe an in-person meeting every 2 or every 3 or every 4 weeks even, and that becomes more of an integrated decision that the client can mostly make, depending on, you know, what their access is and what their preferences are too.
Yeah, I was going to say something really similar. I think my hope is that it continues to be accessible for individuals, whether that means through continued billing flexibility, continued, from a student perspective, continued supervision flexibility, or more access, again, as being in Montana, for rural individuals in Montana. That's my hope.
Yeah, I agree. I mean, I think I don't see this going away at all. You know, I think this is telemedicine has proven to be really useful, and I think our patients really like having the option, and I don't think we're going to you know, stop providing it. So I just hope that everything in the general kind of healthcare world promotes easier access to it and just have it become a normal part of healthcare.
Great. Well, thank you all so much for your time this morning. It's been a really great conversation, and I really appreciate you taking the time to talk about this. So thank you all so much.
Thank you.
Yeah, thank you. Thank you.
I just want to say a special thank you to everyone on this call: Sarah, Robin, Hannes, Jenna, and Yannicka. This was an excellent conversation. And Leah, thanks for inspiring us all. And Mandy has also said thank you all for sharing your knowledge and information. So has been a recorded talk, so I will download it once it's finished sort of processing, and everyone will have access to this. So I'll pass it along to you. I think it's a very valuable discussion for the future. I mean, what a unique time to sort of record what you all have been through and navigating what it's like to be a clinician in the time of COVID. So thank you.